Welcome everyone. As usual, I will brief few housekeeping rules first. Please make sure to rename yourself with a Zoom name similar to that should appear in the participation certificate. Towards the end of the lecture, a link will be shared in the chat box. Please fill out that form for feedback and for your certificate. Note that attending the session for a minimum of 45 minutes and completing this form is necessary to obtain the certificate. The certificate will be sent to you via email within 1 to 2 weeks. Please keep your microphones muted and videos off unless the resource person specifically asks for answers. If you have any questions, kindly type them in the chat box. They will be addressed later. So to start the session formally, good evening everyone. On behalf of the Sri Lanka College of Physicians, it is my great pleasure to warmly welcome you all to the very first session of our CPD for Primary Care monthly program. This initiative was designed with a very clear purpose, enhancing knowledge for better patient care. As we all know, primary care is truly the backbone of our country's health system. The quality of care delivered at this level determines not only patient outcomes, but also efficiency and sustainability of the entire healthcare system. Recognizing this responsibility, Sri Lanka College of Specialist Family Physicians has taken a leading role in continuously upgrading the knowledge and skills of primary care providers across Sri Lanka. Through this program, conducted in collaboration with the Education, Training and Research Unit of the Ministry of Health, we aim to bridge the gap between guidelines and real-life clinical practice, while strengthening the unique family medicine approach to patient care. This platform brings together a diverse audience: general practitioners, OPD medical officers, postgraduate trainees, and doctors preparing for international examinations such as MRCGP, AMC, CLAP, and ERPM, all united by a common goal: delivering better, safer, and more patient-centered care. Today, we are truly privileged to begin this journey with an outstanding speaker. It is an honor to introduce Madam Dr. Malkanthi Galhena, a name synonymous with excellence and leadership in family medicine in Sri Lanka. Madam is not only a consultant family physician of great reputation, but also a pioneer and the first president of the Sri Lanka College of Specialist Family Physicians. Her contributions to the discipline span clinical care, education, policy development, and national healthcare systems strengthening. She has demonstrated exemplary leadership throughout her career, from guiding primary care services at institutional level to leading large-scale national initiatives such as the COVID-19 home-based care program, where she oversaw more than 600 healthcare professionals. As an educator, mentor, and examiner, she has shaped generations of family medicine practitioners, ensuring that our discipline continues to grow in strength and relevance. Her role in establishing and advancing family medicine as a recognized and respected specialty in Sri Lanka is truly remarkable. Today's session on hypertension in primary care, from guidelines to real life precision, is highly relevant to all of us, as hypertension remains one of the most common and impactful conditions we manage daily. I am certain that Madam will provide valuable insights that we can immediately apply in our clinical practice. So without further delay, it is my great pleasure to invite Madam Dr. Malkanthi Galhena to deliver her session. Madam, over to you.
Thank you, Dr. Supun. He is a senior registrar in family medicine, and not a senior registrar, now acting consultant. So sorry about that. And your kind record, the introduction to me, and I'm warmly welcome all the professional doctors who are participating as the audience today. It's the very Supun here that in between time when I ask you to the display the question regarding some to the strengthen their knowledge, kindly please do the share that whenever you
Okay,
wanted,
madam.
whenever I
Okay.
requested. Right, okay.
Okay.
So thank you very much for the trust that you all have put on the Sri Lanka College of Specialist Family Physicians, as we are the regular guideline management updates to provide the best, the safe, patient-centered care for your patients. I highly appreciate your trust, and we are there to provide the guidance in future as well. So coming to today's presentation, because we have selected this topic, so it's management of hypertension in primary care. It's really from guideline to the real life precision. I know for the most of our the primary care doctors who are practicing, after the passing out, and most of are in country not in the getting a facilitation to go ahead with to know the get the skill in practicing the guideline-based management, which is very crucial for the patient safety and as well as to own, the own protection as well. Excuse me for 1 minute. 1 minute only.
Madam, you are muted. Madam, you are muted. We can't hear.
No, she has she got a call. She excused. Please hold on. Madam, still you are muted.
Okay, can you hear me?
Yes, now we can hear you.
Okay. wait මම මේකෙන් ගියා මට පොඩ්ඩක් ඉන්න දෙන්න මොකද මේ මට very important call එකක් ආවඩිය ඉන්න I must rejoin I think ඉන්න මම මේක leave කරලා
නෑ මැඩම්ට සයිස් ටික නම් අර කීප් මවුස් පෑඩ් එකේ ඇඟිලි තුලින් මේ එක්ස්පෑන්ඩ් කරාම එතන මැඩම්ට ඔක්කොම වින්ඩෝස් එක පෙන්නයි ඒකෙන් PowerPoint එක තෝරගත්තා නම් හරි.
right,
දැනට
okay.
ෂෙයාර් වෙලා
right.
තියෙනවා.
Okay. Right. Layout නේ.
ඔව් layout එකෙන් තෝරගත්තා නම් හරි.
Right,
දැන්
okay.
slide ෂෙයාර් වෙලා තියෙන්නේ. ෆස්ට් ස්ලයිඩ් එක අපිට පේනවා.
Present layout. Right, okay. Ari, can you see me now?
Yes, madam. Yes.
Okay, thank you. Right. So we'll start this because the importance is the primary care management in hypertension management in primary care is just not the patient comes to you with high blood pressure and to start the treatment and go ahead. It's far beyond that. So I need to give an correct insight about it, how to manage your patient with the giving the full the safety to the patient as well as the confidence by you in order to provide the international the treatment to the international standards, right? Right. So why hypertension? The need treatment is very important thing. Right. So why hypertension matters? It is the leading risk factor for stroke, IHD, and chronic kidney disease. Not only that, the vision loss, organ damage, right? In a single word is the essential organ damage, is the main outcome of, the uncontrolled high blood pressure. And to say that generally 10 million deaths per year, according to the WHO, the researchers. So, and the high prevalence in Sri Lanka as well. No need to talk about in numbers and all, but you and me are very well aware about the prevalence and how many patients are coming to you and how many new patients are coming to you and how many patients are coming and getting admitted to the wards with, the serious complications where threatening to their life, threatening to their families, everyone. So because of that, it's a real hit to Sri Lankan economy. Being Sri Lankans, we must know how to go ahead with, the guideline-based management in order to minimize this. So definition, according to the NICE, we must go because there are so many guidelines for the high blood pressure. So the NICE guidelines is the UK system that they have taken they have made accordingly by giving all the guidelines and was like the tailor-made to their practice, and it's the same like for us as well. But in Sri Lanka, the primary care guideline had been had been established and had been the published by the Ministry of Health last year with the participation of our college as well. So I was the pioneer to the giving the support there. It's bit of different age category. They have categorized because it's mainly focused for the government hospital setups where because they are thinking about the prevent the complication of high blood pressure among our people, and as well as catering to the in par with the economy and the current available drugs which are in the hospital setup. So because it is bit of different, but they are, in case the primary care doctors who are following that, it's no much of a difference, but whole theory behind hypertension management is same. They have mentioned the age categories different, like 8 years above and 8 years below, but the worldwide, they say mostly the 55 and the more than 55 and the less than 55. But the guidelines, you must know what are the guidelines. That is NICE guidelines, and as well as the European Society of Cardiology, that is ESC and ESH guidelines regarding the hypertension, and ACC, that is American College of Cardiology, and American Heart Association AHA guideline, WHO guideline. We have shaped our primary care guidelines mostly aligned to the WHO guideline, and International Society of Hypertension, that is called ISH Global Hypertension Practice Guidelines, and the KDIGO guidelines, that is for the kidney disease, improving global outcomes. That is another one, particularly BP and CKD, they are talking about that. And American Association ADA standards of care for the BP, blood pressure and diabetes, and the National Heart Foundation of Australia, and as well as the hypertension Canada guidelines and the Ministry of Health Sri Lanka guideline have been revised before this giving this lecture for you all, right? So definition according to that, the clinic BP, right? This is regarding the clinic BP. There are 3 types of BP measurements can be done. That is clinic BP, ambulatory BP, that is 24 hours the patient is wearing that blood pressure monitor and getting the averages of it, and home blood pressure monitoring. There are 3 methods, but commonly out of all, we used to do our hypertension, the diagnosis confirmed by the clinic blood pressure. So you must be aware about that. And this is, it should be 140/90 or more, right? Keep that in mind, that even 140/90 also the taken as high blood pressure, right? And more is the clinic blood pressure definition. ABPM, that is home blood pressure monitoring, there the 135 or more, 135, 85 or more, right? And to say that severe hypertension, the globally, they say it should be systolic blood pressure 180 upon diastolic 120 or more, right? You should not think about it should be more than. It's wrong, the idea that most of the medical professionals think. That is not that. The similar, the value also will be taken as hypertension. So then you must know about, being primary care physician, accurate blood pressure measurement. That is very crucial, because we are going to diagnose lifelong illness where the patient needs the lifelong treatment, the pharmacotherapy especially, which consists of a lot of side effects. And the patient may come across with those side effects more than the disease sometimes. So because of that, carefully you have to select the patient to confirm the diagnosis. So because of that, accurate blood pressure monitoring is one of the crucial, the responsibility of yours. So the rest 5 minutes and be seated is very crucial. Not the time that they come straight to the clinic and to do it. Advise the nurses or the minor staff who are measuring the blood pressure. Most of our clinics, they are the one doing that. Ask them to do in this manner, correct cuff size. And because the larger people, obese people, you have to increase the cuff size, and for the small children should be the lesser size. And both arm first visit. That's very important. And the use ABPM to confirm. The gold standard to confirm the blood pressure is the ambulatory BP monitoring, even though we can't do it at our hospital setups and even your primary care setup. It's not available, but you must know in suspicious cases, so you have to send the patient for the ambulatory BP monitoring and confirm by that. So because of this theory, so I know that most of you all are know about that. And very first time, both arms is very important. That you must know. Because, in-term blood pressure is the one we are going to get it. The difference between, the 10 to 15 the millimeters systolic, is abnormal, right? If it is more than, the 20, it's highly significant. So because of that, this may indicate peripheral arterial disease or subclavian artery stenosis, or the aortic pathology sometimes, in acute setting. But think about the peripheral arterial disease and the subclavian artery stenosis, very rare situations. But you must know why we are telling you to check in the both arms, right? And it improves not only that, improves the diagnostic accuracy. Because if only one arm is measured, the risk of the underdiagnosis or overdiagnosis. But if the arms with the higher reading once you check in the both arms, you have to get the higher reading to diagnose the high blood pressure and for the ongoing monitoring. And if the persistent the in-term differences is there, it's a real predictor of cardiovascular events and the stroke and the mortality as well from the researchers they have proven. So that is why the guidelines say go for the both arm at the first visit and take the high blood pressure measurement, the blood pressure, the categorization for the high blood pressure from the higher arm value. And it is helpful for the detection of the secondary causes and vascular disease as well, like in resistant hypertension and, the asymmetrical pulses, vascular symptoms, those are the things. So, guideline recommendation is that measure BP in both arms at first assessment. If difference is more than 15 millimeters Hg, repeat measurement and use high reading arm thereafter. And the same recommendation, most of the guidelines are being advised for you. And then when to start the treatment? When I will close it through the table. When to start the treatment? Stage 2, treat all. Stage 1, all patients need to be checked, right? You must know the stages of hypertension. Right, okay. Stage 2, treat all. Stage 1, +1, the risk factor, either one or more, you have to treat. But in the stage 1 hypertension without risk factors, only the lifestyle modification. And always, when you are going to start the treatment, you have to consider the cardiovascular risk assessment as well. So the CVD risk is high, and stage 2, the patient belongs to the stage 2 with or without CVD risk, you have to. But stage 1 patients, if you have to consider whether the risk factors are there. So either at one risk factor or more, then you have to start. And the CVD risk assessment you have to do for the stage 1. Again, if the CVD risk is more than 10, you have to start, even though no risk factors are there. Right? CVD risk detection is being done by, in Sri Lanka, not the Q risk, mostly the WHO charts. There you have to take the patient, the WHO chart is available. It must be available at your place. Whenever the patient comes for the hypertension, definitely, so you have to go ahead for the you have to check for the CVD risk, because with the lipid profile and as well as the total cholesterol, then age, and consider about the systolic blood pressure of the patient. These are the three things, but consider diabetic status and smoking status as well in a patient to check that. It's very easy. In our clinic, Panadura Hospital, we always check the CVD risk assessment that you have to start in your practices as well. That is the guideline-based, one of the important thing. And just to mention about the grades, right? There are the normal grade, in the sense it should be less than 140/90. Stage 1 hypertension is equal or more than 140/90. Stage 2 is equal or more than 160/100. And severe hypertension, in the sense more than 180 systolic or the diastolic more than 120. So for the confirmation, this is for the clinic blood pressure, but in the ABPM or the home blood pressure monitor, the management, there we take as grade 1, stage 1 hypertension as 135/85, equal or more, right? So it has been gone down, and in the stage 2, it's 150/95 or more will be taken as the stages of hypertension to treat. So these are the very important thing that you must know your grading, right? So once you come to that, so you are not going to treat for all the patients who comes with blood pressure according to the grades and according to the risk factors. And according to the WHO or CVD risk factor detected by WHO risk chart. So the Q risk assessment are the three things that you have to look for, right? So very important for those things. Any questions, you can, stop it and ask about the things that already I discussed, right? So you are welcome for the questions. The risk factors are there. I'm talking about the risk factors here just for a word to mention about risk factors in hypertension are non-modifiable and the modifiable risk factors. Non-modifiable is the patient who are young patients, they don't have high blood pressure. With the aging only, it's getting due to the vascular stiffness. So age is one of the non-modifiable risk factor, and the family history or genetics, which comes to the patient, also non-modifiable, and the ethnicity, South Asians and the African ancestry has, the higher burden of getting high blood pressure, and the male sex, particularly the younger age group. Also the non-modifiable risk factor, right? And the postmenopausal female. Males towards the young age, but females towards the later age. Because of the estrogen, it protects us from the vascular event. So that is not a risk factor at the young age. So thinking about the modifiable lifestyle risk factors are the high salt intake, 5 to 6 grams, obesity. It's a central adiposity is very important thing out of it. So the compared to the salt intake, the number one risk factor is obesity. So keep that in mind to check whenever the patient comes with obesity, just the patients are not coming with symptoms in high blood pressure. So because of that, the obese patient always try to always assess the blood pressure. Ask your clinic people to check the blood pressure in a correct way to exclude that, because hypertension is not such a disease, comes with symptoms. So you have to look for. So, and physical inactivity, exercise, the excess alcohol consumption and the smoking. It's an indirect vascular risk, and unhealthy diet with low potassium and the high processed foods. So those are the two things that you must identify the risk factors, right? Non-modifiable and the modifiable risk factors. They are, and the medical metabolic risk factors also come into play, like diabetes, CKD, dyslipidemia, metabolic syndrome, and obstructive sleep apnea. Those are also the risk factors. So if you find such a risk factor also in stage 1, you have to start the treatment, right? Even stage 1, without having any the organ damage, you must start. And there are the stage 1 hypertension with the secondary causes. The risk factors are associated like renal disease, renovascular disease like renal stenosis, endocrine causes, primary hypertension, Cushing's or pheochromocytoma, thyroid dysfunctions. If those are there, this is additional risk factor. So you must treat for stage 1 hypertension, that is not the 130, 90 or more, right, for the patients up to the second stage, without any evidence of the underlying organ damage. So now I think you must be clear about that. But the patient comes with no such the risk factors, then you can the go ahead with the patient, the monitoring the blood pressure and the lifestyle modification. That particular patient has the underlying risk factors management can be done. The modifiable risk factors, you have to go ahead, and then you should not be think of treating patients. But whenever you are going to start the treatment, always you have to just can't keep that in mind. Just you can't start the treatment, the having the blood pressure elevated, confirm that you have to the look for because our whole ambition is to treat for the high blood pressure, is to prevent our organs getting into the damage, right? So the end organ, the damage need to be prevented. That is the whole ambition. Out of that, the main thing is the CVD, that is cardiovascular diseases are common. That is, the brain and the heart, but all other organs like eye, the peripheral vessels, kidneys, right? And even the liver, everything. So we have to check mainly the most the common crucial organs are heart and the brain and eyes and as well as the kidneys, right? So you must think about preventing getting into the complication. That is the whole ambition. For that, you have to start the treatment thinking about the correct, the patient to treat. But not all the hypertensive patient, no need to have the treatment. For that, the categorization is there. That is the grade 1, 2, and the high severe hypertension you have to think about, and always go for the surveillance for the underlying risk factors, and then you have to go ahead with the treatment. Okay, I'll come to that. Then guideline-based management is based on these things, right? Just to summarize this thing, confirm the hypertension, right, with the exclusion of secondary causes. That is the primary care I'm talking about. So in case of if you find the secondary hypertension, need to hand over to the secondary the care without any delay, right? So we should not take any responsibility. We should not play on the patient's lives thinking about that you can manage, because we must know our limits, right? Always the guidelines are giving us that limit. So because of that, it's adherence to the guideline management is very crucial in such a way. And the other thing is the correct antihypertensive selection according to the age is very crucial. And end organ damage screening with investigation is another very important thing that most of us are not going to do. So which is very crucial in hypertension, as because you can't play with the people's lives. So that is the knowledge about you all to build up. And the CVD risk assessment, then we have to do by using the Q risk, provided that patient doesn't have any other risk factors. And initiate the correct antihypertensive and the statins. Not only the antihypertensive treatment is not only the antihypertensives, but also the statins as well. It's the parallelly, you have to think about starting the statins, because our ambition is to control hypertension, to save our organ damage, right? And as well as to prevent atherosclerotic plaque formation, right? With the damaged inside the damaged organs, which expedite the ischemia where the organs get the damaged early. So because of that, statin treatment, that is for the CVD risk assessment, is very crucial. And the lifestyle modification is very important according to the etiology, because all the patients are not having all the lifestyle modifications are necessary. It should be tailor-made according to the patient. If the obese patient comes due to the dietary factor, the poor diet, then you have to advise about that, and get not just the advice. Being the primary care physician, we have to make a plan to the patient so that the patient is involving actively, like getting the patient for the monthly review of the weight, and refer the patient to the nutrition, the guidance for the low calorie balanced diet, and get them involved in their management. Giving them the responsibility is the duty, right? So because of that, identify and if the patient is very much careful about the diet, but he is a smoker, then you have to talk about smoking while appreciating the dietary, the manipulation. Like that, you have to select from the patient what to do and not to do in the lifestyle modification, and plan for long-term based follow-up is another very crucial thing, because most of our patients who are coming with complications like, CVD veins, strokes, then, the TIAs, the strokes, permanent strokes, or, the visual threats, and as well as the CVD, the cardiac events like MI, or any other the rhythm abnormalities, as well as the renal failure. Those are the PADs, peripheral articular the diseases are because of they are not being followed up properly. So they will always stop the treatment plan if you are not keeping the very good doctor-patient relationship with the patient by understanding who the patient is, right? That depends on the patient to patient. You have to identify who the patients who are having the poor compliance, and you have to find out why the reason is, and then you have to address that reason. Otherwise, commonly if you address the whole the scenario, so can't be the beyond our control. Like similarly, our secondary care hospitals will be full of our complications. Then you are as a primary care physician, the has been not done the proper job. Right, you must know causes for the secondary hypertension in order to hand over. The common causes are the primary aldosteronism, pheochromocytoma, Cushing syndrome, renal artery stenosis, CKD, and obstructive CKD due to many reasons. Maybe nephrotic syndrome, maybe AGN, maybe diabetic kidney disease, the common thing, right? Or maybe the familial kidney diseases, or maybe recurrent UTI in a prostatic patient without treatment. He has gone to that. The elderly patient, again, for the renal stone which has not been treated like that, there may be several causes. So OSC, obstructive sleep apnea, is another very common cause among young people who are coming with, the uncontrolled diabetics with the high blood pressure status. Because if we are in our clinics, we see a lot of patients are coming with, has been started the antihypertensives, but 2-3 tablets they are taking, but instead that the patient's blood pressure is not going down, because patient comes alone to us, right? There's no evidence. The wife or someone who sleeps with that person is not coming. Whenever the patient comes, they comes with some more symptoms or due to the accidental finding of high blood pressure. If you are, as the primary care physician, is not aware about the possibility of getting the resistant hypertension for the drugs, as the obstructive sleep apnea, if you are not inquired into that, you are going to miss. This is a very common thing that we are going to miss it, but by the time that patient comes, the patient has ended up with complications like LVH, hypertensive heart disease, or the CKD, or sometimes the vision threats. So those are there. So please be mindful about, ask about the obstructive sleep apnea, at least from a patient. The patient might say sometimes, and in an obese patient who has high blood pressure, right? And the thyroid dysfunction are the common things that I just mentioned. And in order to, and hypertension and the investigation, you must know, to do that, to identify it as the primary care physician. So whenever the patient comes, you must know the symptoms of these diseases as well, right? So high blood pressure with, the symptoms of like so much of sweating, and it's, the edema, and, the primary aldosteronism, the symptoms, and the pheochromocytoma symptoms. I mentioned about the pheochromocytoma, the Cushing syndrome, renal artery stenosis symptoms, and CKD, OSA, or thyroid dysfunction, either from the symptom or the blood investigations. You must be aware about that, right? Otherwise, you're going to miss this case. Then these are the investigations that in such a case, if you suspect, you can think about sending the patient to do this investigation. So it's very important for you to know why you are sending this such as the suspicious secondary hypertensive patients to the secondary care. That is to detect the aldosterone-renin ratio, the plasma, metanephrine levels, and pheochromocytoma, and primary aldosterone-renin ratio, overnight dexamethasone suppression test in the Cushing's, and the Doppler ultrasound CT angiography, and the PAD and EGFR, and the urine ACR in case of CKD, and the sleep study in obstructive sleep apnea. So these are the things that you must always, think about this Doppler ultrasound and CT angiography in the renal artery stenosis. So lifestyle, so I told you that whenever the patient comes, you must, identify the things that, you need to manage. So stepwise drug treatment. Before that, you have to know before the start, the stage 1 hypertension and all other the stages, even though you're going to start the treatment. So you must, go for the lifestyle modification for each and every patient, but type 1 patient with no other risk factors, you can manage with the lifestyle, through the lifestyle, but you have to get involve your MDT team management, that is multidisciplinary team, like, the exercise physiotherapy, nutrition management, and, the weight reduction program and smoking cessation assistance, like that. There are several MDT team for you to the help for that. But because of that only, the patient thinks that it's a responsible job and you have to hand over them, because they will take time and do that to show you that the better results. So stepwise drug treatment. So before that, I want to go back to this slide. Guideline-based management, which is the focus of this lecture. So once you confirm the high blood pressure, so once you exclude secondary causes, right? Because from the symptoms, you can exclude, right? Secondary causes. Like in the high blood pressure patient comes to you and confirm the clinic BP or ambulatory BP or home BP. Now, if you think that it's a confirmation is being done, then you have to get the proper history from the patient to exclude the secondary causes, like, ask about the possible causes that I mentioned. They are like, the symptoms are very obvious in, the patients who comes with secondary causes. Always you have to look for that, right? So very, very important for your knowledge about that. If you don't have that knowledge, you are going to miss the diagnosis. So that is very important part. One of the important part that I'm going to give you from this lecture. Right. So when you think about the renal the renal diseases established, facial swelling, frothy urine are the one, and the passing the hematuria, gross hematuria, or symptoms of urinary tract infection should be excluded. But, the other things that you are not aware about, the common presenting symptom of primary hyperaldosteronism, it's very rare, but anyway, you must ask to not to miss the patient. That is the poorly controlled high blood pressure with 2-3 drugs is the suspicion comes. Or before that, you must ask from each and every patient the high yield, the symptom analysis. If you are aware about that, you can do that. That is the muscle weakness. If any patient comes with the muscle weakness, if you think that young patient works, please be mindful to ask about this. The fatigue, lethargy, and the muscle cramps. The patient comes with muscle cramps, we are not going to take the consideration as a serious thing. So we just forget about, don't think so, right? If the patient has the high blood pressure and the muscle cramps, then ask about the muscle weakness and the paresthesia and palpitations, there they will give you, the evidence for that. Like that, the renal, I told you, polyuria, the nocturia, or the frothy urine. And in case of obstructive sleep apnea, the patient may give if you ask the patient, obese patient may give the history of snoring. And in case of the Cushing syndrome, the patient may give the obesity, truncal obesity, and the moon phase, that is by looking at the patient per se, you can detect. But in the being primary care physicians, it's very important for you to know. If you don't know, you're going to miss that. So please be mindful to ask about that. The other the things that I have mentioned is edema also the cause for this one, endocrine causes primary, I mentioned about pheochromocytoma. That is episodic headache. The patient may come with palpitation and sweating. Always ask about these common things, right? Muscle cramps, the body weakness with muscle, the weakness, and sweating, palpitation, and the symptoms of anxiety. And as well as the moon phase and I told you about the weight gain. Thyroid dysfunction, you know what are the symptoms. No need to tell about that. Weight loss or weight gain with the weather preferences. And in case of acromegaly, enlarged hands and feet, like post-facial features. Then coarctation of the aorta, that young patient comes with radiofemoral delay. That is the important thing, that when you're going to check from the the sides of the arm also, you can be suspicious about that. That is at the first visit. And the weak femoral pulse, and the obstructive sleep apnea, it's very common. And other things like the drug addicts also comes as the high blood pressure, because they are giving the history of drug addiction. So that is very, very important thing. So you must know about these symptoms, at least to further find out. Then once you exclude that, so you can confirm your primary hypertension with correctable, modifiable secondary the causes as well, like thyroid dysfunction, and as well as this one obstructive sleep apnea. The cases we can manage most of the time. Once the better, if you are being primary, the physicians that not being in the training, so you have to at least send the patient once to the specialist, either VP to the specialist family physicians are around. So with the basic, the investigation set is very crucial. That is for the organ screening, which is coming in diabetes and high blood pressure is very crucial. Without that, you can't start the treatment. So what are the organ screening tests that you must do, right? That is, you have to think about the possible organ damage, right? To detect it, the before start treatment is very crucial, or at least, because high blood pressure, once you start, even though you have detected the high blood pressure, it's not urgent for you to start the treatment, provided that patient doesn't have any symptoms of the vision, the heart, or renal, or cardiac symptoms are not there. So it's not that urgent to start the treatment. But if you start the treatment in a wrong way, that matters, because the patient may not get the proper control while you are wasting your time and the money of the patient, and the patient is going on the wrong treatment, the complications may be developed. So because of that, it's better to get the initial screening test and you start the treatment should be the best way, right? So because you can start, because it's depending on the person to person with their ongoing, the body, the metabolic, the symptoms, as well as associations, as well as the underlying comorbidity. So you have to look for those things initially, and the organ screening in the sense that you have to do the very first is the lipid profile, and then the renal function like ACR. Urine ACR is very crucial to identify the renal damage before the EGFR and the serum creatinine. But the problem is from one single ACR, you can't, the establish the renal damage, because the urine protein is the very common thing that may pass it through the urine for other reasons after exercise, doing exercise, and after not cleaning sample properly, after not washing it. Like that, even the mild infection can give you. So with that, you have to clarify that the patient has been collected it very well, and the repeat samples, at least in, they say for the ideally the guideline 3 months, once a month, like 3 months, so you have to do the urine ACR and confirm that the protein urea positively for the assessment of renal damage. So if the ACR is positive, then definitely you have to diagnose as it's the urine, it's a renal damage, early renal damage. That is the crucial thing that primary care physician must identify in order to not to progress the disease to the severe renal damage, where it comes with the reduced EGFR and the increased serum creatinine. That is very crucial thing. The other thing is, same time you have to assess the cardiovascular status. That is the ECG, and usually we used to take the resting ECG. It's better if you can ask the patient to go ahead for the 6 minutes walking ECG. It's like, the faster walking, it's like ideally exercise ECG. And, take the ECG and come, or otherwise the normal resting ECG. And if anything, if you think that the patient needs like uncontrolled hypertension for about many years, send for the 2D echo as well, because heart enlargement can be detected either through ECG or in minimal the cardiac enlargement. As a responsible primary care physician, you must detect it early. So where the ECG will not show from the leads, that V1 and V6 leads, there you can detect it from the 2D echo. So because of that, you have to send for the ECG and 2D echo, and as well as the lipid profile, and then the patient renal functions. And the other important thing is urine full report, because secondary causes at very firstly also we have to think about, even though, because if we miss that, the patient will be ended up with so because of that urine full report, in order to check any urine significant proteinuria, and as well as, the other thing is serum electrolytes. In case of serum electrolytes, it helps to detect the electrolyte abnormalities in the condition called Conn syndrome, or as well as, in case of mostly the guideline says the first line is, the 55 years or less patients, the first line is ACE inhibitor. When you start the ACE inhibitors, you have to check the serum electrolyte within the 2 weeks, because to exclude very rare condition renal artery stenosis. So because of that, serum electrolyte also the DIST includes into the DIST. And the full blood count also includes, because full blood count, some patients are having, the polycythemia, where you need to exclude that as well, because there is a very higher risk for getting CVD event. So because of that, full blood count to check the PCV of the patient and hemoglobin. And the other thing is, if you think that patient is so obese, and the sort of the fault intolerant thyroid function as well, in order to the same time to exclude the possible secondary causes, and while looking for the organ damage among the first the diagnosed patient of the hypertension. This is very, very crucial. So don't miss this, right? So think about whenever you're going to treat the patient, to start these investigations, and then to start the management, the high blood pressure treatment. But provided that the patient comes, most of the patient comes with, the no symptoms. So we are detect accidentally or the patient themselves detected due to family history of risk factors or something, and the patient has checked it. So in such a patients, we can do this. But think that the patient comes with some sort of complications of high blood pressure like TIA, or it's sometimes the irregular the palpitations that may be to the enlarged heart due to the uncontrolled high blood pressure, giving them this can be given that the atrial fibrillation, right, in elderly particularly. So in such a case, or the patient comes with some visual blurring, or the patient coming with some the shortness of breath with the elevated high blood pressure. So you can't delay the treatment. So when the blood pressure is confirmed in 2 times the assessment, then you have to without delay start the treatment according to the age guideline. But don't forget to get these set of organ screening and the exclusion of the secondary the causes investigation set within 2 weeks time to get it done and see. Because, and the other thing I forgot is HbA1c in a patient who are coming with obesity and the history of diabetes in the past medical history. So you have to think about doing HbA1c as well, not the fasting blood sugar. Because fasting blood sugar is varies of the patient, it provided that patient doesn't have any symptoms. Because there is a higher chance for you to get through the HbA1c, not only to diagnose the diabetes, but to know identify the pre-diabetes patient. That is also very crucial thing for the primary care physician, not to manage the patient not to go into the diabetes status. So because that advantage is there. So these are the set of questions that you have to, the investigation that you have to do on a the patient before start the antihypertensive. And on history taking, it's very crucial. I told you to ask about the symptoms of the secondary underlying possible disease, the hypertensive diseases, and as well as, the primary hypertension or whatever the hypertension uncontrolled status, they may come with giddiness. It's a common thing over tygo. And other thing is, sometimes the autonomic symptoms like the sort of a chest pain and the palpitations. And sometimes the patient may come with the shortness of breath as well. Or, the other thing is the blurring of vision due to the constriction of the blood vessels there due to the extreme hypertension. The temporary effect may be there. So you have to ask from those symptoms and the complications of such organ damage. Like in case of first patient who comes to you with hypertension, you just ask any body edema, right? Any leg edema, any shortness of breath, and the sort of chest pain, palpitation. Those are the things that, of course, you have to ask. And then you have to go for the past medical history of the high blood pressure. Because patients in our country, not in our country, globally, the most of the patients are being not compliant with the treatment because high blood pressure doesn't have any symptoms. So because of that, they just think, why should I take tablets? Because our culture towards not to take tablets, those are chemicals. So in such a case, you must explore the past medical history of neglected treatment. Because by the time the patient comes to you, the patient must be having some of the organ damage. So where you have to think about very much focus for the start of treatment accordingly. And the other comorbidities, very important, like diabetes and the bronchial asthma, the patients are, whatever the treatment you are giving in acute exacerbation, the patient blood pressure is going up in acute test. So you may wrongly diagnose that the patient's blood pressure control is not enough. That is wrong, right? You have to control that comorbidities essentially. It's very essential. So because of that, you must know what are the comorbidities. And particularly the underlying other illness who are on the long-term treatment. Like, sometimes in rheumatoid arthritis or connective tissue disorders, they may be on NSAIDs for the long term. And without guideline-based, even rheumatologists are being given NSAIDs, so many. So that may be the reason for them to get the high blood pressure. The temporary the reasons also you have to explore, like giving them prednisolone. So for that arthritis. So you have to be very vigilant to find out those temporary factors as well before label the patient as the high blood pressure. For that, your history taking is very, very helpful. So being primary care physician, so whenever such a patient comes, ask about the possible symptoms of organ damage and ask about the other comorbidities, ask about, the psychiatric treatment. Also increase the blood pressure and blood sugar, so must ask. And then go for the other things like, the social factors are very, very crucial. Without asking, you can't go and label the patient, because alcohol is very important in giving high blood pressure and the cardiac, the comorbidities, and as well as, the smoking, right? And there are the food factors, as well as exercise, lack of exercise, and the salty diet and the weight gain. It's very crucial. There are those things you have to achieve for each and every patient. So then finally you have to come for the family history of particular patient, because genes are the strongest where we can't modify. So then we have to know that we can't avoid the genes already in giving high blood pressure. Think of the other modifiable the methods and the pharmacological management for such a patient. So thinking about the patients with prostatic diseases, and thinking about the patient with the angina and MI, right? The diabetes. You have to think about different, the pharmacological approach to the patient to give the proper control. So it's very crucial for you to detect the other information from the history, as I mentioned. So CVD risk assessment, it's a must for you to do the CVD risk assessment. Definitely, without that you can't. The patient is having already the diabetes. Patient diabetic, all patients from the day that we diagnose, we take as the moderate CVD risk. So because of that, we start the moderate CVD statins, right? That is 20 milligram atorvastatin or the rosuvastatin 10 is to be given at the time of diagnosis, irrespective of the lipid profile. So if you find such a disease, diabetes and familial hypercholesterolemia, and the hypothyroidism, they are when the patients are tend to get the lipid disorders. So in such a case, you have to take them as an additional risk factor, right? And no need to check for the CVD risk in such a patients. You can assume the patient is having the higher CVD risk than the normal. If it is more than 10 counts, so then you have to start accordingly the design dose to the patient, irrespective of organ damage. So, but the other things, if the organ damage is proven, the renal damage is there, you have to start with the moderate dose of statin for the hypertension patient, 20 milligram statins, atorvastatin, and the 10 Prosua. And in case of heart disease, it should be established CVD, it should be the 40 milligram or 60 or 80, right? Depending on the patient symptoms. And if the patient, has no any evidence of CVD, the risk, and no family history, no any other contributing factors. So then you have to assess the CVD risk, thinking about the smoking status. And please mute Dr. Jayasinghe. Right, and thinking about the patient's smoking status, age, and the systolic hypertension and the lipid profile. Next visit the patient come, it's a must for you to, like the going through the organ screening with the investigations, you must assess the CVD risk. And they have to then you have to put the patient on statins according to the CVD risk. It's a more than 10 to 20, it's a 10 milligram. It's a more than 20, you have to go for the moderate dose like 20 milligram atorvastatin, right? That is very crucial, and not just initiating the antihypertensive, but to consider about the adding the statins as well. It's very, very important, right? So that is another thing, and why we need to check the organ screening accordingly. We have to check the select the antihypertensives as well. So even though you started according to the guideline, ACE inhibitors, sometimes the second add-on the drug should be selected according from these investigations in case of if it is uncontrolled. Then it is very, very crucial thing, right? Okay. So now you have selected that and you have check the end organ screening and the CVD risk assessment is done. Now you can initiate your antihypertensive treatment and the statins accordingly. For that, I will come to the next slides, and the lifestyle modification is very crucial, and the planning for the long-term medication and the follow-up is very crucial thing, because primary care physicians are being the responsible people for them to get the loss of lives and the complications because of poor follow-up. They have not given the appointments correctly and not doing the annual or 6 months monitoring with the relevant organ screening investigations. Every patient should have a plan to go ahead with the relevant the organ screening investigation. But I mentioned not all the things like at the very beginning we are doing some investigation to exclude secondary causes, but here you have to stick to the investigations to find out the progressive disease like renal function, and the ECG monitoring and the 2D echo assessment and eye assessment, and as well as the urine protein assessment that has to be done. And that is very crucial, and the lipid profile. It's very crucial. The annual monitoring, or depending on the patient underlying comorbidity, it can be expedited to the 6 months as well. It's a better. Right. Now we'll move to the next. So you are going to stepwise drug treatment. So age category 55, less than 55, AC inhibitors are the number one. Enalapril, lisinopril are the drugs that you have to start, not ARB. Right, but if AC inhibitors are intolerant, only you have to go according to the guidelines. So this is, I must say, the most of us, we straight away go to the ARB. So because of that, it's wrong. Maybe due to, the side effects of ACEI, we are going to ARB. Not the AC inhibitors, but it should be the guideline mention first line therapy antihypertensive is AC inhibitors. Not the ARB. So you must know why is that. Any idea? Because I know most of you all will start from the ARBs. That is, they say according to the guideline, strong evidence-based, the evidences are there, because there are some very famous research studies like the HOPE and all had the associate this established ACI benefits in the reducing cardiovascular events and improving mortality. But that is AC inhibitors are the first comers. So during that time they have done that, and compared to the ARBs, the very good outline trials are there for the AC inhibitors, but it's not that for the ARBs. And cost effectiveness also, they say the AC inhibitors are cheaper, right? And other thing is they say both the efficacy comparable to the efficacy, they both AC inhibitors and ARBs are blocking the renin-angiotensin RAS system, reduce blood pressure effectively. So no strong evidence that ARBs are superior to AC inhibitors, but the trials are not much, their trials are more towards the AC inhibitors. So that's why they say the first line is AC inhibitors. and ARB used when AC inhibitors are giving persistent cough or the rare serious the side effect called angioedema. So cost-wise a very important thing is the cost. The cost is very much lower in AC inhibitor. And mindful about that, the AC inhibitors, they cause us, they increase the bradykinin. With that, the vasodilatation and as well as, the no bradykinin effect on ARBs. So because of that, the patient will not get that cough. So that is the thing that they are mentioning about that, the guidelines. But other thing is lisinopril is the drug that, the giving the commonly by the specialist. I have been noticing. So you have to be very much mindful to tell about the side effect of the lisinopril. To think that why not enalapril, why lisinopril, right? So patients who are on lisinopril, I have been about the more than 7-8 patients the detected by me who are on lisinopril comes with the very bad the dizzy feeling, and they say about they are going to get some serious illness like no stamina the around after 10 a.m. 10 to 11 a.m. after that, because once the patient is taken the tablet in the morning, they say that after that no stamina to do the work, fatigue and faintishness, and they are away from the work. And so once you take that tablet out, it's a non-side effect of lisinopril. The patients are very much better. I have a very good friend of mine. She is a medical dental professional. She was suffered like nothing, and she has spent about more than 1 million for the investigation to detect this. But the last 6 months she was the very badly the affected, and the pathetic story is her husband also medical officer, a very much practicing medical officer, never detected this. So once the patient just mentioned about me, that is the suffering that this much of money has been spent, so can't find out. So when I went through that, the lisinopril is there. When I took out and instead that I put him again on the enalapril, the patient recovered very well. So whenever she meets somewhere, she always be grateful to me. So be mindful about the lisinopril, the side effects. So when you are going to start new drugs, you have to be mindful about that as well. Right? Any side effects, at least you have to say any side effects, please come. Then you can check the side effects. So very, very important. So bypassing enalapril, they are going for the lisinopril, right? Specialists. So you must know why should you go to the lisinopril, not the enalapril. So it's having the very good reasons, it's all right, because lisinopril is once a daily dose, but enalapril is twice daily. That is the advantage, right? So because of that, lisinopril is straight away acting to the antihypertensive effect, but enalapril, once you give that, it's a prodrug converted to enalapril in the liver. So provided that the liver impairment is there, so you can't prescribe enalapril. So in such patients, that is all right, alcoholic and all, with the established liver disease, then is it useful in the liver impairment, the lisinopril, and the patient very much the lethargic about going for the twice a day drug, also good, but you have to tell the patient, right? And then stepwise drug treatment. So the age is the cutoff point. 55, the less than 55, you have to give the ACE inhibitors. And when you are going to combine, there is another, the second drug would be the CCB, right? And 55 or more, that is elderly patient, it should be the calcium channel blocker. So why that calcium channel blocker? Equal 55, equal low, the more, right? But in age 55, less than 55, right? This should be equal or more the CCB, the calcium channel blockers, amlodipine, or the calcium channel blockers can be used. But, why this is in the elderly patient, the calcium channel blockers? Because AC inhibitors, in elderly people, this is, they are the vasculature is very much, the resistant. Right? They are the very much resistant in the sense so it's not stretching, and in the age, where the vasculature is there. So, sorry. But not the, it's not the AC inhibitors. So why is that? You must know once you do that, you must know the reason for that. The guideline says something, you have to find out why. They are with the elderly people, the blood vessels are also resistant, and as well as the low renin, the angiotensin, the renin production is very much the less, right? Because elderly patients, they have the very low renin and the stiff arteries are there. So whenever you are going to give that, the peripheral resistance is very much higher compared to the younger one because of the stiff arteries. So because of that, and the renin also low. So ACE inhibitors are the targeting for the renins, but the CCBs, calcium channel blockers, are targeting for the higher peripheral resistance, reduction of the peripheral resistance. So that is better in elderly people, right? While giving that ACE inhibitors, giving the activity depending on the RAS activity, it should be good for the very good renin angiotensin, the secretion people. So because of that, that is the drug that you have to select accordingly. And the elderly people, most of them are having isolated systolic hypertension due to that the resistant, the blood vessels with increased the peripheral vascular resistance due to their stiffness. So for that, it targets very well, right? So that is why you have to select CCB for the elderly people, and stepwise escalation need to be done in monthly monitoring or 2 months monitoring. But initially, you have to get the patient in 4 to 6 weeks time to check the escalation. After establish the treatment according to your investigation results and to the tailor-made basis. So the step 2, 3 is once the patient coming to that for the follow-up, you have to add the ACE inhibitors and the CCB, the next one for all, right? But in elderly patients, the patient are coming with CCB, not adequate, so you can optimize from the milder dose the next. And then you have to, second drug could be the ACE inhibitors, right? And the third drug could be the thiazide-like diuretics. But the more than thiazide, the indapamide is better. But the thiazide is having lot of side effects. So that's why we say thiazide is not a good drug, but we have in our system the thiazide. Compared to if possible, your private patients who are coming to you, if affordable, so go for the indapamide, Natrelix SR, rather than putting the patient on thiazide, because thiazide, the side effects, the profile is, the one thing is the triglyceride. Hypertriglyceridemia is a very well known factor. Getting the patient, even it goes to the 500, 600 levels. So the lipid profile should be very much focused for such a patient to go ahead with the fasting lipid profile in the relevant annual monitoring or 6 months monitoring. because fasting lipid profile is the one going to detect accurately triglycerides. But other than that, when you are going to check the lipid profile, we are targeting to reduce the CVD events risk factor, we are targeting LDL, right? So if you want to do the initial lipid profile with the patients, so even now the current guidelines say you have to go with non-fasting lipid profile, because patients are very much reluctant to do the lipid profile, because of that we are going to not detect our correct to the dyslipidemic patients of this keeping 12 hours fasting. It's not a practice among our people. So now the guideline says they are looking for the non-HDL cholesterol and the LDL rather than, for that, the patient should not be kept fasting. So ask them to when you are write the initial organ screening test, write the lipid profile within bracket non-fasting. Right? Then otherwise lab people say, no, you have to keep fasting for so non-fasting lipid profile, otherwise they will send the patient back. So it happens to us in our clinics, we used to do the non-fasting, right? That is easy. But if you think that, but the repeated, the one, if the patient is specifically put on thiazide, then you have to be focused about, the fasting lipid profile to check the triglyceride level. Other side effect of thiazide side effect is, the gout. There is a higher chance of getting gout if the patient is use alcohol and it's the hyperuricemic meals like meat products. And the thiazide will give you the postural drop as well in elderly patient. So because of that, if you want to go for the selective, like, the Natrelix SR would be the best. And in case of that, now you know how to do that. But third drug would be added. But the first drug, even losartan or ACE inhibitors, you can start from the minimum dose, and then you can start from the gradual, the increase of the drugs, and then go to the second drug. Like that, then go to the second drug, increase the maximum dose, like amlodipine 10 milligram daily or twice 5 at maximum dose should be divide or single dose 10. So you have to go ahead like, and when you are introducing amlodipine, tell the patient that edema will be the problem. In such a case, you can adjust it until, so that thinking about that, better not to avoid that prescribing that, because almost all the people are not getting that. But the patient who is having heart failure and all, so it will, overlap the symptoms. So because of that, try to avoid, because other drugs, bisoprolol is there, right? But otherwise you have to prescribe, that is a very good drug to reduce the peripheral resistance. So coming to the resistant hypertension, we provided that 3 drugs also not, the helping. So, but in such a case, before thinking adding the spironolactone, the drug management always, each and every visit, whenever the patient comes, the weight reduction and, the substance abuse or the alcohol or whatever the bad, the health habits need to be the focus for the reinforcement of the management, because these are the things that very difficult to get away from a patient. But once you appreciate the reduction of the blood pressure in the small amount, but doing 1 or 2 good things, appreciation will help the patient to improve the compliance towards your management plan. So don't try to put the blame on patients. Always try to be connect the more with the patient and understand the background. Sometimes the patient are very shy about telling the financial difficulties and all. So when you put the blame to the patient not getting that, instead, better ask why, what is the problem behind, is it the financial problem? Then you have to think about the cheaper and the hypertensives. Otherwise, patient will be ended up with the complication. That is not the patient fault. Even though patient says just in front of you, the patient is unable to clearly ask. Our clinic, we clearly ask if it's a long-term drug, not just the once a month only for 1 month. So you have to tell us clearly whether you can afford this or not. Then patient comes with that. So because it's very careful of selecting drugs, and for the long-term basis, it should be, the tally with the financial situation as well. That is one of the common thing that you have to address. Otherwise, patient will come with the side effects, not the side effects, of the complications. So third drug is spironolactone, provided that all your drug management compliance and as well as the non-pharmacological management compliance, removal of etiological factor behind the patient should be done, and then think about adding the fourth drug, that is the spironolactone. It should be in the minimum dose, like 12.5, and it should be with the serum potassium level checking only, because it will reduce. So spironolactone is a potassium sparing drug. So once you start that, the patient's potassium levels will go up. So if the patient is already having the damaged myocardium like hypertensive heart disease, there is a higher chance to get with the potassium for the irregular hearts. So because of that hyperkalemia. So you have to be very much cautious about monitoring. Before this start, the spironolactone, you have to do the serum electrolyte. And after that, on your subsequent management also better. Ask about, the check about the serum potassium. It's very important, right? Because otherwise we are putting the patient towards more risk of getting the cardiac arrhythmias. So, and the adherence checking, not only for the pharmacological, I told you, for the non-pharmacological and the etiology removal must be checked. And exclude secondary causes is very crucial. And then coming to the summary of your management, the diagnosis need to be confirmed. Ideally, the gold standard way is ambulatory BP monitoring should be equal or more than 135/85. But clinic blood pressure 130, 140, 90 or more, right? 140/90 also the number grade 1 grade 1 hypertension. So treat stage 1 only if high risk patients, high risk are there for the patient or the family history or other the very high risk behaviors like smoking or but in case of CVD, assess the CVD risk as well. Always assess the CVD risk among the patients of high blood pressure. And think about not only the antihypertensive management, but also for the statin management, the concurrently. And think about the treat stage 1, think about the first line management, guideline-based AC inhibitors, OARB, and the elderly, the calcium channel blockers, about the 55 or above, right? And a stepwise approach is, I have mentioned again, step 1 is ACI OARB, step 2 is ACEI plus CCB, and step 3 is adding thiazide, step 4 is adding spironolactone, minimum dose, 12.5, right? So, and emergency admit if the blood pressure is more than 180, equal or more than 180, 120 diastolic. But provided that the patient, that you have to be very careful in this situation, emergency admission, because the patient has not been taken any treatment. Then, of course, because of the poor compliance, you have to get back the patient for the compliance and find out why this non-compliance, in case that you can make that corrected with the family member or the patient per se. Then you have to give the treatment and to get the patient in the second day and check for the monitoring like that, you can go ahead. But the patient comes with, this much of high emergency blood pressure elevation plus some organ damage, the symptom like shortness of breath, autonomic symptom, and the vertigo, and sometimes the visual loss or something, and then you have to admit, right? But such a patient, you have to look for the being primary care physician. Very first thing is look for the papilledema, right? If you are not competent, so please admit to exclude papilledema, right? But better admit rather than sending home. But if you are competent and you are having a very good idea about the patient, the poor compliance or whatever, something social background, if the patient take the responsibility of getting back into the treatment, then all right. Because sometimes the patient had been gone to a lot of stress, not taken 1 or 2 tablets instead of 3 tablets. And then it's a very obvious reason that we can be back, ask the patient to be back with the treatment and come back for the checking about, if the patient comes morning, you can ask them to come in the evening again to check it. Like that, right? So have to, but the patient has some sort of TIO, some sort of vascular deficiency or some the organ damage symptoms, then you must admit then and there to the emergency. So you have to consider treatment in the high blood pressure for the special population. That is the diabetic patient. Now the AC inhibitors are the first line. But provided that the diabetic patient doesn't have high blood pressure, but the urine protein urea is, the confirm, then you have to add AC inhibitor, right? That is the first line. Even the minimum dose for the night dose would be enough, not to control the blood pressure. But particularly such diabetic patients having high blood pressure, AC inhibitors is the first line, irrespective of age, right? And then the CKD, again AC inhibitors are the first line. But in pregnancy, it's if the patient is on AC inhibitors or the calcium channel blockers, you have to change this immediately to the beta blockers, labetalol. Right? That is it's your prime duty, right? And before the patient coming into that, the patient who are on antihypertensive treatment, because now you don't think that young patients are coming for the hypertension is a secondary always. So the very young crowd used to come with the weight gain and the salty diet and the obesity, sleep apnea are the causes for them to get high blood pressure. So always be suspicious and vigilant to check the end organ screening with such a hypertensive patient and to exclude secondary causes as well investigations. So in pregnancy, young ladies are coming with pregnancy, not for until the pregnant, once they get married, if the patient is known to you being GPs, you have to keep the patient ready for the high blood pressure patient to ready for the pregnancy by changing, by giving an advice to go ahead with once they plan the pregnancies, please come and to alter the medication to the beta blocker, labetalol. And heart diseases, definitely you have to go for the AC inhibitors are the first line. And the prostate disease, it's the first line always according to the age, you have to select the patient, the category of the antihypertensive, and the second line could be the add-on drug could be, you can select, like, the prostate disease, you have to go for the alpha blockers second line. That is the prazosin, provided that the patient educate the patient for the postural drop that can come as a side effect of the drug. And in case of, the patients who are coming with heart disease, first line should be according to the guideline, age related, but the second add-on drug should be the beta blocker, like bisoprolol, or the calcium channel blockers, provided that bisoprolol is not tolerating due to the bronchial asthma, or sometimes the bisoprolol while on getting severe, the bradycardia. There, in such a case, you have to change it. And in case of the comorbidities, then you have to think about changing the correct antihypertensive as a second add-on therapy. The first is the guideline. So its target should be less than 8 years. It should be less than 140/90. But it's more than 8 years. It should be target less than 150/90. Because of the peripheral resistance is needed for them to know the go ahead for the supply of organ transfusion, organ perfusion. If the lower the blood pressure more than that 150 or 90 less, then the organ perfusion will be at a risk. So because that elderly people, we should not be target the so much below, like 140/19, less than 140/19 youngsters. But it should be less than 150/90. But keep the patient around that bit of a higher level target. And home blood pressure, it should be for all 135/85. So monitoring monthly until the control is getting, and then 3 to 6 months after you control the patient. Even you can ask the patient to come in 3 months time. That is all right. But with the correct, the monitoring of the blood pressure at home, or with the control, the close by another doctor in a proper way to get an idea. But tell them in any case of complication comes, so don't wait for the time given for the next to the due date. Renal function and the other relevant organ screening is very much special in such the follow-up visits. Whenever the patient comes, accordingly, appropriately, you have to monitor the patient, the other comorbidities like diabetes, bronchial asthma, or sometimes the nutritional deficiencies, that thyroid dysfunctions has to be monitored and has to be controlled through monitoring well to get the hypertension aligned control. Common pitfalls are poor adherence, wrong measurement, and the clinical inertia. But where we are not getting the patient to the common according to the follow-up schedules. That is very important. And clinical inertia not to go for I know very well it happens that most of the doctors who are practicing as GPs, they are not checking, they are the organ screening. That is very wrong, right? You have to be, and not assessing the CVD risk. So because of that, the patient are ended up with their serious complications of their lives. So take home message is diagnose correctly, treat based on the risk, and the CVD risk assessment is very compulsory, and the lifestyle and the drugs are very crucial, not only the drugs or not only the lifestyle. And regular follow-up according to the patient's comorbidities. You have to expedite the process of follow-up accordingly, and the comorbidity control is very crucial. Not only aligned to get the proper control of high blood pressure, and refer at the correct point for the secondary care if any complication develops, even though the primary hypertension comes with organ screening. If you check that the eGFR is going down and with no reason, like no urinary tract infection, no dehydration, nothing, but it's going down, like the present one, the 45, now it's becoming to, the 35, like. So you have to find out why it is. The same for the patient to the nephrology, right? The patient comes with stable angina. Instead of that, your blood pressure and the organ screening are being done well. The patient are being placed on the correct medication for the beta blocker plus ACE inhibitors as second, and the correct, the hypertension control, but patient is getting, then you have to send the patient for the cardiology for detection of, any problems like the ambulatory BP monitoring, or with plus or minus the cardiac assessment by the cardiologist. Like that, you have to go ahead with the correct, the endocrinology referral for the thyroid dysfunctions. Once you get the correct, the control of the blood pressure, but instead that the patient to the thyroxine deficiency is the waving off. Like that, you have to get the appropriate secondary care opinion, even though the primary, the management, the hypertension is primary hypertension. So I will give you the few questions for you to give me the answer. I have given the answer, but I'll explain that. They are 62 years old male with a history of hypertension, presents for a routine medication review. His current blood pressure is 152/92. That is, the 62 years old It's more than 55 years. And the patient's blood pressure is this much, right? Despite compliance with amlodipine, 5 milligram once daily, he has no history of diabetes mellitus. A recent the echocardiogram performed due to mild the exertional dyspnea demonstrate evidence of left ventricular hypertrophy. LVH is there. What is the most appropriate next step in his pharmacological management? So, add lisinopril, increase amlodipine to 10 milligram, add indapamide, add bisoprolol, add doxazosin. Patient is correctly on CCB, and second add-on therapy should be to control the blood pressure, right? Not anything else. So according to the guidelines, after 55 years, they say to go ahead, first CCB and second is ACE inhibitor. So here the lisinopril is the answer, right? I told you why they have given CCB, not the ACE inhibitors first line, elderly patient. So here why A is correct according to the NICE hypertension treatment algorithm. Patients who are not controlled on a single agent like calcium channel blocker, the second drug is to add an ACE inhibitor. So ARB, ACE inhibitors are especially beneficial in patients with hypertensive heart disease, particularly left ventricular hypertrophy. Yeah, it's a cardiovascular remodeling is there. As they promote cardiac remodeling and they offer renal protection. Cardiac remodeling and renal protection is they both are there. So in uncontrolled hypertension, the two vulnerable organs are heart and as well as the kidney. So both way, this is really good. So ACE inhibitors is the one. So next question, only one I have put, no? There is another one. Here. Another one, another case. Right. Here, I hope that you can see, no? Kasun, can you see the screen?
Yes, madam.
Okay, dear, right. So 48 years old, another. We'll go to the slide show, wait. "48 years old, the male, right? Present that is less than 55 years. Routine in the health check. His clinic blood pressure reading is 148/92. So what was the target? It should be less than 140 to 90, right? In 48 years, less than 55. He is asymptomatic, has no history of cardiovascular disease. And his physical examination is unremarkable. What is the most appropriate next step in the management of this patient in primary care, right? Start lifestyle modification, review in 6 months. The problem patient is a younger patient and the blood pressure is not that controlled, but he is asymptomatic. No any other, the diseases behind, comorbidities, no. Physical examination, normal. But you need to achieve, it should be below 140/90. So what to do? So start lifestyle modification is not enough. And start antihypertensive therapy with amlodipine 5 milligram. Offer ambulatory blood pressure monitoring and perform ECG and request fasting glucose and lipids. Refer to a cardiologist assessment. This is the grade 1 hypertension because, the blood pressure, the patient, has not been diagnosed as high blood pressure, but you have to have a doubt whether this patient need to have, because no organ damage as well. In case of organ damage is there, it's the 100, it should be the mild elevation, that is grade 1. So in grade 1 hypertension, you have to check whether the patient's lifestyle modification to give first, whether this is always throughout, is it the same? So in such a case, so you have to confirm the blood pressure first. So you have to put the patient on ABP monitor. This is the critical, the tricky, the places where you need the ambulatory BP monitoring. But in another case, like the patient comes with, the blood pressure is 130, 80, 85, we'll say. But whenever you check for the organ screening, we'll say the patient is having strong hypertension, family history of hypertension. And here the patient is now having, the blood pressure is, the 135, 85, the clinic blood pressure. So when you check, right, sometimes it comes as 130, 140, 85. So you are on the fence. So then in such a case, you must order the ambulatory BP monitoring. And the other thing, because the ECG shows that cardiac hypertrophy, that shows that whenever the patient not in the clinic may be getting some high blood pressure, may be associated with some stress places. Stressing places are the working environment, family, maybe more than stress at the clinic. So because of that, you have to find out how it goes during that time. So the 24 hours ambulatory BP monitoring is a very important thing. And another thing is, there are patients who comes with the mask hypertension. That is again, so when we are checking for, some other medical screening or something, or sometimes the patient comes with another illness, or they are concerned about checking their organ screening with the strong positive family history, or the patient is smoking or something, then you find that patient is having some the renal, the urine ACR positive, or the serum creatinine is bit of elevated towards not the normal, not the elevated, but in between the upper limit. If in such a case, if you check for the ambulatory BP monitoring is the one you have to, they're very much helpful in order to detect whether the patient is going unmasked with the hypertension, masked hypertension. At the clinic, they come and say the checking normal, but whenever they go back to their stressful place, the patient's getting high blood pressure for about many years. So you have to check that. So it's very crucial for you to check that ambulatory BP monitoring for such a patient, to name the patient as the high blood pressure patient before progressing for the other organ screening. Although the patient is having some damage, the blood pressure is not there to tally with that. So definitely it's the place for you to send the patient for the ambulatory BP monitoring. And even home BP monitoring also advised for such patients. If the patient is not willing to go for the ambulatory BP monitoring because they need to give some deposits to check that, and long keeps are there, so ask the patient to buy the blood pressure monitoring, like the validated BP monitoring like Omron. So then ask them to check, the BP the morning and the evenings and the night, like the 2-3 assessment according to the home BP monitoring guidelines. So then get the report and come to the decision. But gold standard is ambulatory BP. If possible, send the patient for the gold standard. Right. And these are the references that I have gone through. And I will, tell you, always be mindful about the guideline-based management by assessing for the organ damage screening and the cardiovascular risk assessment in order to go ahead with the correct, the selection of your the antihypertensives to the patients, your patients, and to go ahead with the statin therapy and adjust to the the fasting lipid profile initially, and go for the follow-up with the fasting lipid profile in the set of investigations that where the lipid profile come as the very high, the indication. So these are the things that I need to talk about you regarding blood pressure management. But the comorbidities management is very crucial. because comorbidities in such as the COPD patients, the bronchial asthma, the chronic renal diseases, and other cardiovascular problems. So they are the very important thing is those organ damage also contribute for the CVD risk finally. And be mindful about, whenever the patient comes with erectile dysfunction and the high blood pressure patient, always they are coming to ask about exclude the high blood pressure for such patients, coming to ask for the tablets for the erectile dysfunction, but consider as a priority for the investigating them for the hypertension and the underlying CVD risk by doing all organ screening and the CVD risk assessment. They are having higher CVD risk. So put the patient on the moderate dose of statins at least, provided that no established cardiovascular disease. And to educate about the possible heart attacks and encourage about, encourage more about lifestyle modification according to the patient's behaviors. And then give the priority for the erectile dysfunction. And the other important thing is, when the diseases like rheumatoid arthritis or the connective tissue disorders and psoriatic arthritis and the recurrent gout patient comes, there may be some underlying possibility for them to get hypertension or, the other CVD risk. So please, be mindful to screen them for the organ damage, very firstly, while treating the disease, but not to forget about the CVD risk side and identify any underlying the risk for the CVD events like high blood pressure and the cardiac damage or the renal damage. You have to treat with the moderate to high dose of intensity statins parallel to the treatment course of the disease and maybe plus or minus antihypertensives. So there is another 5 questions that I have selected before coming into this thing. So I need to go that to share. That can you share that, Supun?
Sure, madam.
Share, so you can.
Is this okay, madam?
Right. I can't see. All right. No. All right. So, okay, I can see. Right. This is don't show the answer. This patient, just the very simple things. A 52-year-old, if you can send your answer to the chat box, I would be grateful. 52-year-old asymptomatic, the man is found to have the clinic BP 152 to 96 during a routine check. He has no target organ damage. What is the next best step in management? Age you have to consider. You have to select out of the best from the answers given. Right, go to the answer. Yeah, very good. So arrange, most of you all have answers. Arrange ambulatory BP monitoring because we have to detect whether this is the blood pressure, because no target organ damage. So you have done your job. You have, once the patient comes with this confirmed blood pressure, you have checked the screening for the organ damage, and CVD risk assessment you have done, but no, nothing is there. So in such a case, you have to confirm with that at least go for the grade 1 lifestyle modification. But to confirm that. So that is the important thing, right? So go down little. They are nice recommend confirming the diagnosis with ABPM when the clinic BP is more than 140, 90 or high, prevents overdiagnosis because white coat hypertension also there. Why others are wrong? A, the treatment should not start without confirmation, and B, delay risk missing diagnosis because ECG is a part of assessment, not the confirmation, and the blood tests are important but not for confirming diagnosis. But they have mentioned about no organ screening, but check renal function first is not the thing because all the organ screening has to be done. But before that, to do the organ screening, you have to do the confirmation of the blood pressure, right? Otherwise, it's a waste of time because systolic white coat hypertension, occasionally the blood pressure due to the stresses will go up, right? Next question. So 48 years old woman has ABPM average, the blood pressure of 142 to 92. The age is again less than 55. She has no diabetes, CKD or CVD, and Q risk is less than 8. Right? Again, this patient is, what is the most appropriate management? Start antihypertensive medication, lifestyle advice only, start statin, repeat ABPM in 1 month, start dual therapy. What is the best appropriate management? Very good. That answer is B. That is go for the lifestyle advices only according to the patient's lifestyle, right? Not the common way. So you have to be focused for the tailor-made lifestyle. So antihypertensives are being started for the grade 1 hypertension once the organ screening is being done and found that the positive, the risk factors. So it's not going to do any other risk factors are there, right? So that is not the case, but once such a patient comes, so you have to go for the lifestyle modification. But when such a patient comes, confirm from that, if there is any answer is there, the next important thing is to know go ahead with organ screening, right? But if it is not here, but it's being diagnosed, provided that no organ damage through the screening, and then you have to go for the lifestyle advice. That is correct. Okay. Next question. Question number 3, 60-year-old, think about Afro-Caribbean, they have mentioned about, that is diagnosed with hypertension, no comorbidities. So what is the most appropriate first-line drug? ACE inhibitor, calcium channel blocker, thiazide diuretics, and the beta blocker. You have to think about ourselves, but right. So you go to the answer. . guideline recommendation is for the Afro-Caribbeans also, the less than the age more than 55 years, they say the calcium channel blockers. Why it is because they are also Afro-Caribbeans also have the low renin levels, they say. So because of that, the patient should be given the CCB first, and then combination is the ACE inhibitor. So this is correct. And our people, the more than 55 years also same, right? Good. Answers are good. The next one. This is regarding resistant hypertension. 60 years old patient is on. That is so that even with 3 drugs, the patient to the high blood pressure is not getting control, being primary hypertension. So you have to ask about the management. So the reply, the 68 years old patient is on ACE inhibitor, calcium channel blocker, and thiazide-like diuretic. Blood pressure remains 155/95. It's not achieved yet. It should be less than 140/90, but it is not that 150/90. The focusing about. So next best step, add beta blocker, add spironolactone. Add beta blocker, add spironolactone, increase ACE inhibitors, and switch to ARB. And can't see the E supun. Supun, E can't be seen.
Add alpha blocker.
Add alpha blocker, right. This is resistant hypertension. We were talking about that. There should be the spironolactone, but I told you before that you have to check the serum electrolytes. And while ongoing the treatment, also you have to check the serum electrolytes, right? Because to minimize the risk of hyperkalemia, particularly in cardiovascular comorbidities. Next. Can you send the other explanation before the final question? Can you go back to that? Yeah. This is the explanation, resistant hypertension, step 4, at low dose spironolactone. If the serum potassium level is equal or less than 4.5, right? It should not be more than that. So please be mindful about that. Being primary care physicians, it's very crucial. And the people who are eating a lot of fruits and also you have to be very careful about that. And if the patient is being educated, patient will come with the voluntarily to do the serum electrolyte reports. Why others are not, others are wrong, not first choice in resistant hypertension. That is the ACE inhibitors and already on optimal triple therapy patient. So because of that, what is the number B? C? Supun, see there, no, above. Go above. There. The increase ACE inhibitors, right? Now go down, please. There. So already on optimal triple therapy, no indication unless ACE inhibitors intolerance. ACE inhibitors, this ARBs. Consider only if spironolactone is not suitable for to add the alpha blockers, right? Okay. The next, the final question. The hypertensive emergency, if the 58 years old man presents with BP 200 and 130, headache, blurred vision, and the papilledema. It's very good, the indications are there. No poor compliance, nothing, but instead that the patient, even though the patient was not the poor compliant, but this patient has to be admitted with the complications of it. The patients who come with no complications, and when you carefully check the patient, then patient can be observed under that for your even emergency treatment unit can be given the treatment and observe the lowering of the blood pressure, or if the patient is close by, very reliable, and ask the patient to go back and come to check that. But here with this end organ damage, the evidence like the headache, blurred vision, and the papilledema, it's the most appropriate management is, the immediate hospital admission. That should be the B. Go for the explanations, please. So immediate hospital admission, it's hypertensive emergency, severe BP plus target organ damage. So requires urgent IV treatment in hospital. That is why we need to admit. Others are wrong because oral therapy is too slow, adding the oral drugs and dangerous delay in case of, what is the C? Please repeat BP after 30 minutes and reset no, not at all. Start AC inhibitors in clinics very wrong, and lifestyle advice is only very wrong. So any questions for you all? I can answer if you have any questions to clarify. So we are being very happy, to give you the guidance, because I know because 256 participants had been joined with us now for this session. That says that you all need this, the updated the guideline management for the common disease that we are dealing with, common encounters. So our college, Sri Lanka College of Specialist Family Physicians, are always thinking in terms of being medical officers to close to you all in order to give a better the primary care, the guidance to practice your practice your medicine, practice your the consultations to your patients with the dignity and the patient-centered way to establish the patient safety in this country, which has been not there for about the decades, because most of the secondary care and the tertiary care physicians are the one providing these, the CPD events where it's not tailor-made to the primary care level. So we being primary care level physicians, we must know we have to have our competency to establish the doctor-patient relationship in order to gather the correct, the information, and as well as the examination skills. And, the other thing is to provide you all the evidence-based management once you find out the correct and the problem. So this is not only for the hypertension and the NCDs, we are meddling with all the age groups, irrespective of the disease, of the all the age groups and the sex, both sexes. So they are in future as well, monthly wise, we give you this sort of a very useful, the practically oriented, the guideline-based management tips. So please be with us, and thank you so much for being with us and the trust that you develop on us. And they are ready to help you in order to answering questions and the giving you the guidance and everything. So as a friendly manner, so not being away as specialists from you all. So we are the same team to help you all by giving the hands to strengthen our care in order to go for the common goal. So thank you very much. And I thank you very much for the being the CPD committee chair. I'm very much humbly thankful to our CPD committee group, Dr. Bhatnanakar and Supun, and all the other team. And special thanks goes to you all. You are very much committed to provide your evidence-based care to your patients. So we'll meet up on another session. And thank you so much. And I urge you all to get the membership of the college. The associate membership can be taken for most of the DFM holders and the others, and we are thinking in order to provide you the college membership to the other doctors who doesn't have such the family medicine qualification as well. So we will be coming with that information. So thank you so much and all the very best. Okay, if any questions, you can send you through the chat box. I can give you 5 minutes and after that I'll wind up you. Good night and thank you very much for all of you all.
Thank you, madam. Actually, there were more than 365 participants at one time until about 20 minutes before. So it's not 250, madam.
No, I said so, sorry.
Thank you so much, madam, for the nice session and this insightful guidance.
Thank you. So, no questions, so we wind up, right? Thank you very much. Right, okay. Good night to all of you. Thank you, Supun. Special thanks to you. Okay, bye.
Good night, madam.